Hello, this is the oral cavity surgery tutorial presented by the SchrDbb with reference SRB Manual of Surgery by SchrDbb Bart. So here we're going to visualize oral cavity pathology and surgery. So here we start with the first one, which is a ranula. So what is a ranula? A ranula is just a cyst which is usually located underneath the tongue. That is the simple definition of a ranula. A ranula can be considered just as a cyst or located underneath the tongue, full stop. So that's the definition. So after having the definition of a ranula, we have the clinical presentation of a ranula. So the clinical presentation of a ranula, we have a smooth, soft fluctuant mass located underneath the tongue, which may, so a smooth, soft fluctuant mass located underneath the tongue, which is very brilliant on translumination. So translumination is just a test where you take light and you place it as shown here. So you place light at the level of the ranula, and you're going to visualize that it's going to be brilliantly illuminating, as you can see here. So now you need to know that there are two main forms of a ranula. So you can see, as you can see, so the ranula can exist in two main forms. The first form of a ranula is called a simple ranula, or the second form is a plunging ranula. A simple ranula is one that is going to be located only at the level of the mouth, so it's only inferior to the tongue. Are you getting? While a plunging ranula is one that is going to enter into the cervix, so there's a neck. It's going to enter the cervical part of your head, so it's going to have a cervical extension. Are you getting? So now, so when you have a ranula, so those are the two main types of ranula that you have. You have a plunging ranula and you have a simple ranula, or a oral ranula. Are you getting? So these are the two main parts. So you need to know that it's a bluish swelling on clinical presentation. You have a bluish swelling at the floor of the mouth, or that's underneath the tongue. So it's going to be usually non-tender, it is fluctuant. So every time you hear the word fluctuant, you need to point out the fact that it goes for a fluid containing substance. So an abscess is going to be fluctuant, any cyst is going to be fluctuant. Are you getting? And they are always also soft. And when you have something that is brilliantly illuminating, just know that it's a fluid filled substance, usually not an abscess. So it's a fluid field, but that fluid should be transparent usually. So that is the first part. So the differential diagnosis, what are the differential diagnosis of a ranula? You have a lymph cyst, you have a sublingual dermoid, as you are going to see, you are going to visualize here. Now, what is the general first line investigation that you do for a ranula? So the first line investigation you can do here is an ultrasound of the neck. That's the first simplest investigation you do for all oral cavity mass or neck masses. You do ultrasound, but you can also do a fine needle aspiration to visualize if there is any pre-malignant lesion or there is any malignant lesion. So now, what's the treatment? So the simple treatment you can do is first an aspiration. So you just aspirate the ranula. That's the simplest treatment. The next treatment you can do is marsupialization. Marsupialization, what's the meaning of that? It means that you cut through the incision and then you open up the borders of the incision such that the fluid can continuously leak. That is called marsupialization. You cut through the incision, you open up the borders of the incision so that the incision can continuously leak outward. That is marsupialization. And then the third thing that you can do is excision of the cyst with the capsule. You need to know that a ranula has a soft capsule. If you excise all the ranula with the capsule, you are not going to have remittance. The next form now of the treatment can be now excision of the ranula with the glands, because the causes of the ranula, based on the pathophysiology of ranula, how is the ranula formed? A ranula is formed when a cyst become blocked, when a duct become blocked. So when the duct become blocked, you have accumulation of fluid in the posterior behind. Because of that obstruction, you are going to have accumulation of fluid behind that blockage. When you have accumulation of fluid behind that blockage, it's going to now produce a mass. Are you getting? Now that some glands that can be blocked in that way can be the sublingual gland, as you can see in this case, or it can also be the submandibular gland. So that's why, in order to prevent the remittance of the ranula, you can also do excision of the sublingual salivary gland, and you can also do the excision of the submandibular glands. So now, as a point to note, now marsupialization has a high recurrence rate. So if you just open the borders and then leave the borders open, you're going to have a high recurrence in 50% of cases. While when you do excision of all these cysts, you have a recurrence of less than 2% of cases, and then you have to take care of the lingual nerve. And the lingual nerve, as you have seen in the anatomy, if you want to revise the anatomy of the oral cavity, just go inside our tutorial and visualize it right now. So we have said there that we have the lingual nerve. The lingual nerve is a branch of the trigeminal, the mandibular part of the trigeminal nerve, and that branch is only supplying the anterior to the general century of the tongue. It does not supply taste of the tongue. For the taste, it comes from the chorda tympani, which comes from the fascial nerve, which is at the level of the middle part of the ear. Is it clear? So every time you have to do the surgery here, you have to take care of the lingual blood vessels and the lingual nerve, which is the part of the SNR or the part of the mandibular part of the trigeminal nerve. So now the next thing that we're going to visualize now is sublingual dermoid. So before I continue, I'm just going to explain generally what do we mean by dermoid. You need to know that usually most dermoid cysts are located as a midline cyst. So they are midline cysts. Why is such case occur? So mostly the part of physiology of dermoid cysts is that usually when you are in the embryologic origin of all human beings, you always have fusion of the left and the right side of the body. Is it clear? So usually in the embryologic origin of all human beings, there is fusion of the left and right side of the human body. Now when there is fusion of the left and the right side, and then the skin overlaps into the fusion, we are going to have a cyst which is having normal skin tissues. Are you getting what I'm saying? Just imagine that you are fusing two parts of your skin, and then the parts of the skin that was supposed to be above enter inward. Are you seeing? So when it enters inward, it's going to produce a mass inside, and that mass is going to contain the normal skin structures. That's why sometimes dermoid cysts may contain hairs, and the hairs are normally located on the normal skin. It contains keratin, squamous cell tissues, which are found on the normal skin tissue. It contains sweat glands, which are found on the normal skin tissue. Is it clear? So that's general pathophysiology of a dermoid cyst. Now in this case, you have a dermoid cyst which is much more located at the sublingual. It's a sublingual dermoid. So here we are going to have sequestration of dermoid. It's mostly going to be a squamous cell carcinoma with containing keratin, because it just contains the normal tissue, as I have told you. So the clinical phenomena is that it's going to be soft, it's going to be smooth, it's going to be fluctuant. But in this case, unlike in the case of a ranula, it's not going to be trans-urinating. So now the next thing that you're going to have now are the differential diagnosis of a dermoid cyst. So the differential diagnosis, you have a hemangioma, you have a lymphangioma, you have a sublingual dermoid, you have lipomas. Now, what is the general investigation that you do for every cyst, every mass inside the neck? The first thing that you have to visualize is to do an ultrasound, and if you're in a case where you have a high developed country, you do an MRI. So, but in this case, a CT scan is not going to be appropriate. Why? Because a CT scan is much more shows things which are with bone density. So if you want to visualize things which are affecting the bones, it's better to use a CT scan than an MRI. Why? An MRI is much more going to be specific for things that are having much more soft tissues than bones. So that's the thing to visualize. So but ultrasound is mostly used for things that have soft tissues, and it can be used in a low income country because it is easily affordable. So now the next thing that you're going to visualize is the type. So the type that you have, so you have midline sublingual dermoids. So these are the two main types: midline sublingual dermoids, and you have lateral sublingual dermoids. So the midline sublingual dermoid, as you can see the name, it is located midline, and the general treatment is excision through the oral approach. So you enter through the mouth and then you excise it. The complication of the midline is going to sublingual dermoid is going to be an abscess formation. Now the lateral sublingual dermoid, we are now going to have here so it's going to be located, as the name implies, laterally, and then the treatment here is just a removal per oral, still through the transoral approach. Now the next thing that you're going to visualize now is stomatitis. So what is stomatitis? Generally, stomatitis is just inflammation of the oral cavity. So that is the name, stomatitis. Inflammation of the oral cavity is stomatitis. Now that inflammation can be due to trauma, it can be due to radiotherapy, it can be due to chemicals, it can be due to nutrition, it can be due to infection. If it's due to trauma, it's going to be called traumatic stomatitis. If it's due to malnutrition, it can be called an aphthous stomatitis. An aphthous stomatitis usually presents with painful ulcers. Let me just show you an image. General image of an aphthous stomatitis is I can see the image. So that's generally for an aphthous stomatitis. So an aphthous stomatitis usually presents with painful ulcers. When you're going to come to the image, I'm going to show you. Then the next one that we're going to have is a candida stomatitis. Candida stomatitis is among the one that was due to an infection. So it's due to when you have an infection with candida, you have a candida stomatitis. Another one still due to infection is a virulent ulcerative stomatitis. In this virulent ulcerative stomatitis, here you are going to have usually here you have ulceration, and here you are going to have slough tissue at the level of the gingiva. So you have the gum, you have ulceration with slough tissue, yellowish slough, and it is the patient having fetor, the mouth is smelling, and to say the general clinical term for that is fetor oris. And also the patient is also going to have signs of systemic involvement, just like fever, is going to be having a high respiratory rate, is going to have a high tachycardia and all that. So these are the signs of systemic toxicity. The patient have that in ulcerative stomatitis. So if you have that in a patient with ulcerative, a patient having ulcers inside the mouth and then having fetor with sloughs inside the ulcer, just think of Vincent's ulcerative stomatitis. And the cause of Vincent's ulcerative stomatitis is Borrelia vincent and fusiformis bacterium. So now usually it exists as a single bacteria causing that disease, but you may have a case where it is polymicrobial. And usually the simple treatment with that is by using penicillins, and by also you remove the slough. So generally the principle of the management here is going to be, the first thing is to treat the source of the infection, the primary focus of the infection, and which is the mouth. So since the mouth is the primary focus of infection, you have to remove the slough tissues, and you have to debride the slough tissue, and then now you treat the systemic toxicity by giving antibiotics. In this case, the antibiotic best preferably targeted, so it's best preferably given is penicillins and metronidazole. The next one is nutritional stomatitis. Nutritional stomatitis occur when you have a vitamin B deficiency. In case of a vitamin B3 deficiency or vitamin B2 deficiency, you are going to have it. Even vitamin B9 deficiency, vitamin B12 deficiency, vitamin C deficiency, and even iron deficiency anemia, which is also called a siderobenic stomatitis. So now angular stomatitis, the next one. And angular stomatitis is usually due to candidal infection and streptococcal infection, and it's also called cheilosis or cheilosis pelegi. Now you have now the next one, which is cancrum oris. Cancrum oris is just a severe form of a Vincent's stomatitis. So just infection of the mouth like this is called a cancrum oris. So it is just a severe form with ulceration. Vincent ulcerative form is stomatitis. Is it clear? Here in for the investigation, just ask for the x-ray of the bones to visualize if there is any bony infection, osteomyelitis of the mandible or the maxillae, and then you do now the swab culture, to visualize if there is any to visualize the source of the infection and all that. But usually the diagnosis here is clinical. So the treatment, so how do you treat now this? You use penicillins, you use pentronidaz. So you have now first the goals of the principle of treatment of every infection. The principle of treatment of any infection is first to kill, to treat the primary focus of the disease. In this case, the primary focus is inside the teeth. So you can have a very good oral hygiene. So you have very good oral hygiene. That's a general measure. You can use also oral antibiotics, and you have to do also debridement in order to remove all the soft tissues and all tissues which are having excessive of the bacteria present. Now the next thing is now to treat now the systemic disease, and treat the systemic disease by using penicillins and metronidazole. If now there's osteomyelitis, that's one complication. You can now do osteopetrosis, osteoperforation. So you perforate the bone and then you leak out all the pus tissue which is inside, which is going to be found inside the mandible or the maxillae. And it is also complication like sinusitis. You can also perforate the sinuses and then leave it to leak out to leak out the drainage. Now you have the other lesions of the mouth, like syphilitic lesions. Now syphilitic lesions of the oral cavity are mostly divided based on the three forms of syphilis. So you have three main forms of syphilis. You have primary syphilis, secondary, and you have tertiary syphilis. Primary syphilis presentation in the oral cavity is mostly going to be by the cank, just like the cank of the genitals, like the cank of the penis and the cank of the labia of the woman. So here you also have the cank of the lips in case of syphilitic lesions. The second thing, in case this is in the case of a primary syphilis, in case of a secondary syphilis, you are going to have mucus patches. You are going to have patches of mucus, and those patches of mucus patches. Patches are just defined as, you need to know you have semiologic terms. You need to know your semiologic terms. Patches are flat lesions which are greater than 1 centimeter, while macules are flat lesions which are less than 1 centimeter. So in this case, like in cases of secondary syphilis, you're going to have mucus patches, and those mucus patches are going to be grayish white, and this make you think also of Koplik spots. But in case of Koplik spots, they are instead macules. Which are grayish or white, and they are also found inside the lips, and that make you think of measles. Is it clear? But in this case, when you have patches which are grayish white, make you think, and in an adult, it has to make you think instead of a syphilitic lesion. And that is going to show you secondary syphilis. In addition to that, you can have mucus patches may fuse to produce snail track ulcers. So they may fuse to produce snail track ulcers. And you also have some Hutchinson condyloma. So condyloma are just raised, these are instead raised lesions. So instead of having patches, you may also have raised lesions which are called Hutchinson condyloma. Those condylomas inside the mouth. So normally you have condyloma you can have a condyloma on the genital, which is genitalia conjugata, or in case of condyloma acuminata, which is caused by human papilloma virus. But in some cases, you have condyloma papularis, which are caused by syphilis, and those condyloma papularis can also be found in the mouth. When they are found in the mouth, they are called Hutchinson condyloma, and they are present in secondary syphilis. Now in tertiary syphilis, you have gomatous painless ulcers. You may have ulcers, many ulcers, which are still painless, and they are found in the anterior two-thirds of the tongue. They are not found in the cheek like in the cank. The cank usually this is single macule, painless macule. So a cank is single painless ulcer. Are you getting? Why in gomatous painless ulcer they are multiple, and yet they are present on the upper and the lower lip, the cank. Why the gomatous painless ulcers are present at the level of the anterior part two-thirds of the tongue. They are present at the palate and they are present at the nasal septum. Then the next one is the syphilitic chronic glossitis, also present in tertiary syphilis. Now, the next lesion that is present inside the mouth is going to be the leukoplakia. So, what is leukoplakia? So, leukoplakia is just considered as white patches inside the mucosa of the oral cavity that cannot be characterized clinically and pathologically to any other disease. It means that what? It means that when you have white patches inside the mouth, the white patches may be due to the syphilitic, as you have seen. It may be due to Candida albicans. It may be due to any disorder. It may also be due to even poor oral hygiene. But when clinically and paraclinically, pathologically, you see no lesion, there is no Candida albicans present in it, there is no syphilitic guma, you see clinically and paraclinically there is no attributed lesion to that, just call those white patches inside the mouth leukoplakia. So example of this is a leukoplakia on the cheek. Now we have types of leukoplakia. We have homogeneous leukoplakia, which is uniform white patches with less malignant. So the characteristic of homogeneous is uniform and it has less malignant potential or conversion. The next one is nodular. Nodular is just fine, it has fine nodules and it has more malignant potential. And the last one is a speckled leukoplakia. Speckled leukoplakia is white flecks with both fine nodules and it is atrophic erythematous base. So when it is nodular, like this one here is much more uniform, not nodular. Since it's much more uniform, it's going to be called a homogeneous leukoplakia. So this one is going to be less malignant form. Why? When it is nodular, it's more malignant, and when it is speckled leukoplakia, it means that it is both nodular and it has an erythematous base. This one is the most malignant form, but it's a less common form. So these are the features. We said it may be speckled, it may be homogeneous, speckled, and nodular. The other forms that you have on clinical features may be erosions. Erosions is you need to know that an erosion is a superficial excoriation, while an ulceration is very deep. So when it is less than 1 centimeter depression, it's going to be called an erosion, while an ulcer is when it's more than 1 centimeter depression. Is it clear? Now we have hard and you have indurated type, which can also be seen clinically. So hard and indurated. Indurated is just meaning hard. When it's roughed, it's said to be indurated. So when you have polarization of epithelial dysplasia, it's also said to be a feature of leukoplakia. So it is. So the features you have white is grayish, well localized. We have it's usually painless and non-tender. 80% occur at the age of 40 years. Hairy leukoplakia. The name hairy is a misnomer. It's a misnomer. It does not contain hair. It just, the surface look like hairy due to it does not contain hair. It's just a misnomer. But it has been called hairy leukoplakia just because the surface look like hairs due to one, thickening, corrugation by severe hyperkeratosis and acanthosis. You need to know that hyperkeratosis and acanthosis are the lesions that can be seen pathologically on histopathology. Now you need to know what are the common causes of any dysplasia inside the oral cavity. The general characteristics are the 8S of the common causes of any dysplasia inside the oral cavity: smoking, spirit, sepsis, superficial glossitis, syphilis, spices, sharp tooth, susceptibility, like in vitamin deficiency, are the 8S involved in any dysplasia inside the mouth. In addition to that, you have a chronic hypertrophic candidiasis, you have human papilloma virus, and you have chewing of tobacco. And that chewing of tobacco is the most associated with dysplasia inside the mouth. Chewing of tobacco or chewing of certain leaves like snake lime, even snake lime, you have areca leaves and all that. Now, the treatment of leukemia is you have to stop the 5S, the 8S, all the 8S that we have said initially. You have to stop it. You have to excise the lesion, and you have to do regular follow-up to prevent the conversion into a malignant form. Now, the next one is erythroplakia. In case of erythroplakia, it's not going to be white cheese, it's going to be a raised lesion which is instead reddish. That's why it's going to call erythroplakia. And now erythroplakia has a 50% for 50% cases going to be converted into a malignant lesion. It will seem like a leukoplakia, but the typical thing is that here is going to be instead reddish and not whitish. The treatment, you have to do biopsy and surgical excision in case of an erythroplakia. Now, the next lesion of the mouth is the oral submucosal fibrosis. In oral submucosal fibrosis, as the name implies, there is just fibrosis inside the mouth. The etiology is due to a hypersensitivity. Any hypersensitivity to anything like tobacco may cause the fibrosis inside the mouth. Vitamin may cause fibrosis inside the mouth. So fibrosis, anything that can result to an increased proliferation of the connective tissue inside the mouth, is that oral submucosal fibrosis. So here the treatment is mainly based on reducing the precipitating factor like spices, the chills, the alcohol, tobacco, that is going to cause more of the fibrosis. You have to maintain oral hygiene. A good oral hygiene is going to kill all the, is going to remove most of the bacteria that are going to promote the fibrosis. You have local injection of dexamethasone. Dexamethasone can also is a corticosteroid, reduces connective tissue formation and fibrosis formation. You have chewable hydrocortisone tablets. So those are also corticosteroids. So you have to make sure to give corticosteroid in this patient to reduce fibrosis. Also, if corticosteroid do not work, now you can now go to human chorionic gonadotrophins, which are an interferons called chicine. Now these are immunosuppressants to prevent to reduce the to suppress the immune system so that it does not cause more fibrosis, and then you have to do a surgical excision. Now submucosal fibrosis. So this is generally what you have to know on submucosal fibrosis. You have already said it. Now the pre-malignant conditions of the oral cavities. So now you need to know that what there are certain conditions in the oral cavity which are much more, which are considered to be having malignant potential, as we have already seen. We said this condition can either be divided as high risk of becoming malignant, you have medium risk of becoming malignant, or you have equivocal risk. High risk of becoming malignant, you have leukoplakia, erythroplakia, and you have chronic hyperplastic candidiasis. Medium risk of becoming malignant, you have oral submucosal fibrosis, as you have seen. You have syphilitic glossitis when you have those Hutchinson condyloma, when you have syphilitic cank, when you have gomatosyphilitic of the tongue. All that can be considered. Syphilitic glossitis, you have sideropenic dysphagia. Sideropenic dysphagia occur in case, as you can see, sidero in medical term means iron. When I say sideropenic, I just mean that I have low level of iron. So when you have low level of iron, it can also predispose you to so sideropenia is just defined as iron deficiency without anemia. So when you have iron deficiency without anemia, it is named as sideropenia. So, or you can have other cases like Spluma-Vinson syndrome, which is a triad of three things. We have the first thing, which is protruding tongue. The second thing, which is a small jaw, like micronatia. You have protruding tongue, you have micronatia, and you have cleft palate. So that is plumar Vinson syndrome, usually a congenital disease which has ECD-opinion. So those are the medium risk, and then the third one is the equivocal risk lesions. The equivocal risk lesions are oral lichen planus, but this one is much more defined on a histopathology. You have diskeratosis, still defined on histopathology, and you have discoid lupus erythematosus. So these are the pre-malignant lesions which are summarized here. We said leukoplakia, erythroplakia, chronic hyperplastic candidiasis, oral submucosal fibrosis, syphilitic leucitis, penic dysphagia, oral lichen planus, discoid, and all that. Now, the next thing that you're going to visualize now is oral cancer. So when you want to visualize oral cancer, the first thing you have to know is the epidemiology of the cancer. You need to know that usually cancer in Africa oral cancer is not usually prevalent in Africa. Here is mostly located in Asian country and Indian country in 40% of cases. So now you need to know that what are the risk factors now of this oral cancer. The risk factors are those 8S that we have seen initially. We said all those 8S are among. Now, in addition to those 8S, you have tobacco, alcohol, betel quid, areca. So those betel quid, I think, is those leaves where tobacco can be produced from. You have human papilloma virus is also involved in that, in oral cancer. You have precancerous conditions like leukoplakia, erythroplakia, chronic candidiasis, chronic hypertrophic candidiasis. We've seen that. You have previous cancer. If you have previous oral cancer, it's a family issue. If you have a family history of a squamous cell, any squamous cell carcinoma can give you, it's a risk factor. Sunlight exposure, mostly in people that do not have melanin. Diet low in vegetables and fruits, weakened immunity, graft versus host reaction, which usually occur in blood transfusion, and then or you have graft versus host reaction, which occur when you have any transplantation of an organ, and then you have lichen planus. So those are certain things. Generally, you can just take anything that is going to cause any metaplasia inside the oral cavity is going to cause an oral cancer. So if you take burn, any acidic juice, anything that may cause any metaplasia is going to cause that oral cancer, as easy as that. So these are the cases where the flaps can be taken. I'm not going to speak more about that. The cheek anatomy, to visualize the anatomy, just go on the anatomy that you have seen. It's generally there, but what I'm going to emphasize on is the retromolar trigone. So what is the retromolar trigone? This is very important because when the cancer goes to the retromolar trigone, the cancer is said to be an advanced cancer. When an oral cancer goes to a retromolar trigone, it's said to be an advanced cancer, and then you have to remove the mandible of this patient. Is it clear? So retromolar trigone is actually is starting from the anterior surface of the ascending ramus to the posterior part of the lower molar. Is it clear? From the anterior surface of the ascending ramus to the posterior part of the lower molar. So that is the trigone. When the trigone is usually affected, it usually shows now a very advanced cancer. Generally does that. So malignancy of the oral cancer, we say the most common malignancy is squamous cell carcinoma. Minor salivary gland tumors can also be present. Minor salivary gland tumor can be present. You have melanomas, then adenocarcinomas, then sarcomas, then basal cell carcinomas. Now, the site of the cancer. So in India and then Western countries. So here we are much more in Africa. So here that's what we have more. So you have the tongue, you have the floor of the mouth, the lips, and the cheek. While in India you have the cheek, which is the commonest. You have the tongue, you have the floor of the mouth, you have the palate, and you have the lips. So those are the areas which are involved in preference. The tongue is the first in the Western country, the floor of the mouth, then the lips, and then the cheek. Now the pre-malignant lesions, you have already seen all these pre-malignant lesions. We are going to speak about that. So these are some structures of the better. I think these are leaves which are involved with production of tobacco. So these are leaves that are involved in production of tobacco. When you chew it, it's a risk factor of those oral cancer. So these are other presentation of oral cancer. What is the preclinical feature of this oral cancer? You may have an ulcer which present. You may have a pain which is involved with the skin. Secondary, you may have halitosis. And what is halitosis? Halitosis is bad odor. Is common in many oral cancer. It's just a fetor, but this fetor is not just fetor, but it's very bad odor, and this is due to necrosis as a result of the cancer present inside the mouth. That is called halitosis. So you said you can have you can have an ulcer, you can have pain, you can have halitosis, which is necrosis, which is fetor oris, but very pungent fetor oris. You have involved in the retromolar trigone. When you have the involvement of the retromolar trigone, it indicates an advanced disease. That's why you need to do bimanual palpation. When you do bimanual palpation and the space between the anterior ramus and posterior part of the molar of the inferior molar is involved, just know that it's an advanced case. So you can also palpate and you have an ulcer which may have an everted edges, like this one here. This ulcer is not having, you see the edges are raised. You have raised edges, so it means that it's much more cancerous. So you have the next one. You have mandible examined by manual palpation of the mandible. The next thing that we can have is trismus, and trismus is inability to completely open the mouth, and you are going to see the grading of the trismus later. So you also have some submandibular lymph node involvement, so and the upper deep cervical lymph node involvement. So now the staging, generally the staging, like for all the other cancers, this is what you can see here. You have everted edges, as you can see, everted. So the staging, generally, like for all other cancers, the staging is going to be with the TNM classification. So that is it. If you want to have a look, just pause it and then you visualize it all. So now the features of advanced cancer. So what are the major features clinically that the cancer is advanced? One, you have involvement of the retromolar trigone, is showing that the cancer is advanced. Two, you have extension into the base of the skull and the pharynx. Three, you have fixed neck lymph nodes. If you have fixed neck lymph node, normally the lymph nodes may be palpable, maybe like movable. If you have fixed neck lymph nodes, advanced. Extension to the base of the skull is advanced, and you have extension to the opposite side is advanced. So what now are the problems of the cancer? You may have an upper airway disruption and you have a bronchopneumonia. That's the first problem in oral cancer. You have feeding difficulty and severe malnutrition. That's why in this patient, since there is this problem, you need to give, the first thing you need to intubate the patient, or you do to do a tracheostomy such that the patient can have another airway supply. The next thing, you have to do feeding of the patient by total parenteral nutrition. So that's the next thing, or you can use nasogastric tube for nutrition. The patient is going to have immunosuppression, maybe because of the proliferation into the bone tissue. So you need to make sure that you give prophylactic antibiotic to this patient. Secondary, sepsis, uncontrollable. You have uncontrollable bleeding again. Why? Because it proliferates to the bone marrow and suppresses the production of the thrombocytes. You have fixed secondary fungation disability, psychological trauma. Every patient who have any chronic disease is having a psychological trauma. That one is for sure. And then you have trismus inability for you to open the mouth. And when you have inability for you to open the mouth, you need to know that's why you have that's another reason why the patient has to take a total parenteral nutrition, or you do by nasogastric tube feeding. Now, the main histologic, you need to know that there's a difference between the staging of a disease and the histologic rating of a disease. Staging of the disease is just how the disease has proliferated all through the body. That's the staging of the disease, and the staging is by TNM staging. Why the histologic grading, the grading of the disease or the classification of the disease, is made histologically. The classification of the disease can be done clinical classification of the disease, or it can be a histological classification of the disease. Usually, classification is done histologically, and the classification is said to be well differentiated or poorly differentiated. So we have the broadest histological classification, which is well differentiated when we have greater than 75% epithelial cells resemble the normal epithelial cells of the tissue of the oral cavity. Moderately differentiated when you have 50 to 75 resemble the normal epithelial cells of oral cavity. Poorly differentiated when 25 to 50 resemble the normal epithelial cells of oral cavity, and then very poorly differentiated when less than 25 resemble. It means that more than 75% do not resemble. It means that it's very poorly differentiated, and that has the poorest prognosis. So now we have present grading system, so it's still the same thing. It is well differentiated and all that. So every time you have a cancer patient, what is the management, what is the investigation that you are going to ask? So the first investigation is first to support their cancer. So to support the cancer, you can ask for any tumor marker. So usually but there's no particular tumor marker for the oral cancer. But usually, if you want to just to support your diagnosis immediately, you can ask for tumor marker and can use fine needle aspiration of the lymph nodes, or fine needle aspiration of the tumor to visualize. So when you have done that, generally you can support your diagnosis of a malignancy. Now, after supporting a diagnosis of malignancy, now you confirm, and you can also do an imaging, say brief imaging by an ultrasound, or you can do a brief imaging by, in this case, since you're at the level of the mouth, you're going to do an ortho-panto mammogram. So an ortho-panto mammogram is just a visualization of the mandible of the face. So you can do an X-ray of the face, or you do ortho-panto mammogram and do ultrasound. So those are the things that can help you to support your diagnosis. Now, to confirm your diagnosis, you're going to do a biopsy and histopathology. Now, after confirming the diagnosis, you need to know that a cancer, in the pathophysiology of the cancer, we have the primary focus of the cancer, and then you have the systemic part of the cancer. You need to know that in order for you to know the extension of the cancer, you need to do also a CT scan, because the CT scan can show you how the cancer has spread. And if the cancer is a form of cancer which has hormones, you can use, instead, unlike using a CT scan, you may use instead a scintigraphy, bone scintigraphy, in order to find the extension of the cancer. But if you don't want to find the extension of the cancer by scintigraphy, the best thing to visualize the extension of the cancer is by positron emission tomography, where you instead use a 5-fluoro glucose instead of using the normal glucose, as you know, 5-fluorodeoxyglucose. Now, the next one that you are going to visualize here is panto. You have said panto mammography. You have also to ask for relation of the dentist. As you can visualize here, you can see there's this extension into the bone. So the panto mammography shows there's a lucency here which shows some extension to the bone. So now, how do you treat this patient? Like all cancer patients, you need to treat the primary. You need to first shrink the disease. That's by a neoadjuvant chemotherapy. Then after shrinking the primary focus of the malignancy, the next thing is to do surgery by removing the primary focus of the malignancy. Then you do a locoregional removal of the primary focus by radiotherapy, and then you continue with the systemic removal in the case of a spread. Now, surgery, you do wide excision you can do either wide excision of all the tissue, but when it has already spread, you can do hemimandibulectomy, and when you have spread again more, you have to do neck lymph node block dissection. So you remove and dissect. You have to do also radiotherapy, you have to do chemotherapy. So those are the three main strategies of treatment. So now, after having the three main strategy of treatment, you have also reconstruction surgery, but I'm going to speak about that. the next thing I will speak about the problems of surgery in this patient, the problem of radiotherapy in this patient, the problem of chemotherapy in this patient. Problem of surgery is that mutilation. Mutilation means that what your organ, your face is not going to be the same as before with surgery. With surgery, you are going to just imagine that you have a hemimandibulectomy. You have removed all your mandibular bone. There is no, I'm not sure there is a prosthesis that's going to replace the mandibular bone for your face to be as normal as before. So that's why it's called mutilation. You lost part of your body. Second thing, you have anesthesia complication. As you already know, you can just say the operative complication. In this case, you have bleeding, you have infection, as you know, you have flap necrosis. Sometimes you may place a flap there, but it may not have any good blood supply and it may cause. You have requirement for reconstruction, you have mortality, you have morbidity. So morbidity, like you have contracture at that place there, you have cosmetic problem, you have problem with neck dissection. So the next thing is a problem now with radiotherapy. Usually radiotherapy is not good on the neck. So what are the problems that radiotherapy can cause when you're at the level of the neck? You have number one, you have osteoradionecrosis. It means that what's going to necrose the bone which is going to be radiated. That's one. Two, you have loss of sensation. So when you have loss of sensation, you may have also loss of sensation at the level of the neck, or you may even have you may have odinophagia, so loss of sensation. You may have more pain, so allodynia. Even when you just touch your neck, you are feeling much more pain. So you have the next one, you have infection, mucositis. Mucositis is going to be just infection inside the dental, so because of dental disease. You have skin excoriation, as you can see here, the skin is excoriated. You have trismus here, you have inability to open the mouth. You can have dysphagia, you have odinophagia, you have because of laryngeal edema. You have hypothyroidism when the neck is irradiated because your thyroid tissues are dying. You have carotid artery atherosclerosis. So you have because the arch is also dying. So most of these may have also visual impairment, shoulder and neck dysfunction, all that. So problem now with chemotherapy. The problem with chemotherapy is that you can have bone marrow suppression. In this case, you have GIT symptom because usually chemotherapy makes people vomit like methotrexate, vomiting, diarrhea. You have megaloblastic anemia. So because these are competitive inhibitors of the immune system, so you can have the vitamin B12 deficiency. You have hepatotoxicity and renal toxicity with immunosuppressant therapy. You have alopecia and you have nausea and vomiting. So the prognosis factor, the prognostic factor of the oral carcinoma, the first thing is the stage of the cancer. Stage 1 and stage 2 have got 80% 5-year survival, while stage 3 and stage 4 have got the lesser, that's 20% in 5-year survival stages. So you know stage 1, stage 2 based on the TMN classification, it was shown there. So I'm not going to speak more about that. So when the carcinoma involves the posterior 1/3 of the tongue, is worse prognosis. When it involves the cheek, the floor of the mouth, it has the intermediate prognosis. Best prognosis when the carcinoma involves the lips, but when the more it is posterior, the more it is worse prognosis because it's much more associated with the internal neck structures. Now histological positive notes, so you can have note has survival rate by 50%. When your notes are positive is not good. When there is OD extension, when there is grading, the grading of tumor is not good, is already another problem. So based on this, we can just put the conclusion, the prognostic factor to be number one, the location. The more it is close to the deepest structure, the more it's going to be worse prognosis. Number two, we have the grading of the cancer. Grading of the cancer based on what? Based on the histology. Number three, we have the after the location, we have the staging of the cancer. The greater the stage, the worse the prognosis. Number four, after the staging of the cancer, you have the number of lymph nodes involved. So the number of lymph nodes involved, and so those are the major 4 elements that you can see. And number 5, also the thickness of the primary tumor. So those are the 5 main things which can be involved in this case. Now After that, now we have the lips. I'm not going to speak about the neoplasms of the lips. The next thing you're going to visualize here is the laryngeal carcinoma. So the next thing, just wait a minute. So under laryngeal carcinoma, you need to know also that the major elements involved in laryngeal carcinoma is going to be smoking, tobacco, alcohol intake, occupational elements like mustard gas, asbestos. You have previous radiation, genetics like Russians develop familial laryngeal cancer. Also, I've realized there are also some people in our country that have a history of laryngeal carcinoma. So I think so that it can also be taken as a genetic factor. Already 3 people in the family had the laryngeal carcinoma. So this is also a big topic. So you have papilloma virus, you have keratosis, and you have malnutrition. So now the incidence of laryngeal carcinoma, the most of the laryngeal carcinoma is going to be squamous cell carcinoma, and it is much more present in males. All the people that I've seen with laryngeal carcinoma were males. Actually, that's the ratio of 10:1, and the person that I know with laryngeal carcinoma was at 54 years, actually show with the fit to syndicate. Actually, that's that. Now it exists now there exist 3 anatomic types. We have the supraglottic type, which occur in 25% of cases. We have the glottic type at the level of the glottis, which occur in 65% of cases, and we have the subglottic type occur in 2% of cases. The person that you know had a glottic type. Now this is generally the anatomy of the glottis, of the larynx. So the larynx is made up of the epiglottis. Here we have the hyoid bone. Here we have the thyroid cartilage. So connecting the thyroid cartilage and the hyoid bone, we have the thyroid membrane. Connecting the cricoid, here is the cricoid cartilage. Connecting the cricoid cartilage and the thyroid, we have the cricothyroid membrane. Now in the cricothyroid membrane internally, we have a fold inferior here, which is a true vocal cord, and a fold superior here, which is a false vocal cord. Here is the arytenoid cartilage. Now the arytenoid cartilage now is connected with the epiglottis here above to form the aryepiglottic fold. Now the glottis, where is the glottis located? The glottis is going to be located at the level of the true vocal cord. So it's going to be just 1 centimeter, so just 0.5 centimeter above and 0.5 centimeter below the true vocal cord. Now we have the vestibules now that separate the false vocal cord and the true vocal cord. Now these are the 3 forms of the tumors here. We have the supraglottic tumor, we have the glottic tumor, and we have the subglottic tumor here. So these are the 3 main forms of the tumor. So now the treatment. So how do you treat now this? So the staging first. So the staging is still based on the TNM classification. You have the staging of the cancer. What is the clinical feature and what are the investigations you do in laryngeal cancer? The clinical feature, you have a patient, since it's close to the vocal cord, you're going to have hoarseness of voice. You're going to have pain and discomfort. You may have cough, dyspnea, cough because there are cough receptors located in the larynx, dyspnea because you may have the protrusion into the laryngeal opening that may cause obstruction. You have dyspnea, you have stridor just because of still that obstruction. You have dysphagia in late cases. You have bloody sputum also in late cases. You have palpable neck nodes. You have absence of laryngeal crepitus. So it's common in males. That's a ratio of 10:1. Now the investigation you can do here is to visualize the larynx. So how do you visualize the larynx? You can use now a laryngoscopy. If with an indirect laryngoscopy, you can do a direct laryngoscopy. An indirect laryngoscopy is just to place a mirror where you're going to visualize the larynx. So you can do a direct laryngoscopy by placing a camera that's going to visualize the larynx, and then you do a biopsy. You can also do a CT of the neck. CT scan of the neck is very useful in order to visualize for the extension of the cancer. The next thing is to do a chest x-ray. Chest x-ray may help you also for the extension of the cancer if it has gone to then do a fine needle aspiration. Fine needle aspiration and is coming after you have done, before you have done the biopsy instead. You cannot do fine needle aspiration after. This is the fine needle aspiration of the lymph node. So in order to know if there is extension to the lymph node, yes, correct. But if you want to do final aspiration of the tumor, you will do it before you do the biopsy. Now you have micro laryngoscopy is small lesion. So you have micro laryngoscopy small lesion to do proper biopsy. Okay, then you have toluidine staining, so superficial cancer to facilitate accurate biopsy. So you can also do toluidine staining in order to know which is the lymph node which is much more closer to the which is draining the tumor. So you can see here that the patient has undergone a tracheostomy and he has a permanent tracheostomy here. So you can now, and he has also done we have a laryngectomy. So in this case, all the larynx has been removed and then the permanent tracheostomy has been placed such that the patient can breathe from here. So that is what is involved here. The last thing that we are going to visualize, so the treatment in this patient, the treatment here is only the same. We do primary focus of the infection of the disease by doing surgery and also by doing radiotherapy and also by treating the systemic spread of the disease by using chemotherapy. So in this case, you have radiotherapy, and radiotherapy is most commonly used in cases of epiglottic and in case of supraglottic or glottic type. But in case of subglottic type, radiotherapy is not very used. So the next thing that you have to do is also laryngectomy. You have a partial laryngectomy and you have a total laryngectomy that you may do. The patient that I have seen had done a partial laryngectomy. So you may do a partial laryngectomy, total laryngectomy based on what you have in front of you. Now the next thing that you can do is chemotherapy. Now the chemotherapy involved here is only to treat the systemic part of the disease. Now the last thing of the day is trismus. Trismus is just defined as the inability for you to open the mouth, and may be caused by cancer, it may be caused by fibrosis, it may also be caused by systemic disease, like it may be caused by either primary or systemic disease. Now with local diseases like what you have fibrosis, we have infections, we have inflammations, and we have malignancy. While systemic disease like tetanus can cause a trismus, a case of hypercalcemia, anything that can cause muscle contraction is going to cause a result to that. Now trismus now is having a classification, and that classification is the Kanner and the Andrade group classification of trismus. So the Kanner and the Andrade group classification of trismus classify it in group 1. Every time you have a patient with trismus, you have to find the interincisional distance, the distance between the two incisors. If the distance is greater than 35, is group 1. If the distance is between 26 to 35, that's or 25 to 35, is group 2 of Kanner and Andrade group classification of trismus. If it is between 15 and 25, it's said to be group 3, and if it is less than 15, it's said to be group 4. Generally, group 4A is said to be pre-malignant, is not malignant status, while group 4B now is considered now to be malignancy, involved with pre-malignant status and malignancy, while group 4A is not involved in malignancy. Example, in case of tetanus where you have trismus, while group 4B is now when it's involved in malignancy. So from here we are finished with everything involved with oral cancer, oral cavity pathology. So we say thanks for your kind attention. Please don't forget to like and subscribe all our videos. Thank you.